So thank you, Arthi. And I just want to say on behalf of the vascular medicine section and then as well as the cardiovascular division, it's an absolute honor. Most people who've been observing the last 5 minutes can tell that we have the extraordinaire Josh Beckman here to give grand rounds today. Josh is known to many of us from his long tenure in Boston at Brigham and Women's Hospital. He graduated from the University of Pennsylvania with a bachelor's in American political history, and then went back home to New York to get his medical degree from NYU. He subsequently continued his training at Presby Hospital, where he completed internal medicine, was a chief medicine resident, a cardiovascular fellow, and then came to Boston finally in 1996 to do his research and clinical fellowship in vascular medicine at Brigham. He was recruited on the faculty and became a key member of the vascular medicine section at Brigham and Women's Hospital. And many of us who trained in Boston have a fond memory of Josh as the director of the cardiovascular fellowship program, which he ran for 8 years. Josh was recruited to Vanderbilt in 2015, where he founded the section of vascular medicine. And under Josh's tenure, I have to say that vascular medicine section has become one of the premier programs in the country. In addition to all of this, Josh has remained a very active physician scientist with NIH funding and research interests in exploring the mechanisms of how diabetes impair vascular function, as well as the effects of endothelial function on non-diabetes related insulin resistance, androgen deprivation, and vascular function in bypass grafts. Nationally and internationally, Josh is known as a thought leader in vascular medicine. He's held key positions in all our major societies, including serving as the prior president of the Society for Vascular Medicine and the incoming president for Viva Physicians. He's the chair-elect of the AHA-ACC Guidelines Task Force and is an associate editor at Circulation. I could go on and on and on. That was my summary of Josh. Personally, I had the privilege of meeting Josh in 2012 when I started cardiology fellowship at Mass General, and he was the program director at Brigham. I learned quickly that when I was near Josh, I had two things were going to happen. I was going to learn something new, and I was going to walk away laughing. He's been a key mentor for me since then, including serving on my K23 advisory board and really as an advocate. And I am incredibly thankful for all the support he's provided, both myself and our growing vascular medicine section here at Beth Israel. So Josh, thank you very much for agreeing to speak today.
Eric and Rob and everybody, it is a real honor and privilege for me to be able to be there. And I got to tell you, I'm incredibly depressed that I can't be there in person. You guys have been building such an incredible program, both in vascular medicine and just writ large in cardiovascular medicine, that I really would have liked to be able to be there and meet with folks and go out to dinner. This is why the pandemic is really suboptimal, among many other obvious reasons. Here's some relationships with industry, which are not really going to come into play today. And I'll just say that one interesting thing about moving to a new place is that you continue to have some similar questions that you want to answer, but all of a sudden, all of the deck chairs on the ship are rearranged. And you have to figure out the new layout, which allows you to talk and work with new people, answer questions in a different way. So I want to set up this talk by basically saying, I want you to know where I'm coming from and how I was looking at PAD, and then what I think is really going on. And we'll start off with just a little bit of background for those of you that do things that are not PAD. I don't know who you are and what you're interested in, but I think it's reasonable just to start with some simple stuff. PAD is a worldwide problem of more than 200 million people, and probably somewhere in the 12 to 15 million people range in the United States. It's the second most common clinical manifestation of atherosclerosis. And as everybody in this audience knows, when you have PAD, you have a higher rate of adverse cardiovascular events. The other thing that you have, if you take a look at the really now antique cartoon on the left, is that you have pain when you walk, or your walking speed is diminished and you feel worse. For the first decade of this century, everybody thought that things were going really well. And I'm just going to draw your attention here to the amputation line, either in the group with diabetes or the group without diabetes. Yes, the diabetic patients had a much higher rate, but in truth, we were beginning to conquer that problem as rates were dropping. And so we were all hopeful that whether it was the increase in endovascular approaches, the decrease in surgery, the better medications, that PAD was going to become a less severe issue. But unfortunately, as we take a look at the second decade of this century, it turns out that we're not doing nearly as well as we hoped, and that there's been a turnaround. There's been a bump. And if you take a look at the patients with diabetes in the top here, somewhere around 2009, 2010, there was a big jump in all amputations, minor amputations, and even major amputations are now moving up. So I think it becomes really important to begin to figure out what is causing the lower extremity symptomatic component of peripheral artery disease. So I'm going to start off with a really simple concept. This is a description of the ankle brachial index. Everybody in this game knows what this is. This is where we measure the blood pressures in the arm and in both pulses in the leg. And we use the higher pulse pressure in the leg and use it to create two ratios, one for the right leg and one for the left leg. And we use the higher blood pressure in one of the two arms. So we form an index, a ratio. And a normal ratio actually for healthy people is about 1.1 to 1.2. We make the diagnosis of PAD with an ankle brachial index of less than 0.9, which means that the ankle blood pressure is 90% or less of what's going on in the arms, our best representation of systemic pressure. But the key to this figure, and you can see this was published 20 years ago now, is that I want you to remember that the ankle brachial index is a representation of basically straight line conduit artery flow from the heart to the ankle and to the arms. So when I think about blood vessels, and I describe this to like lay people, I describe the conduit arteries basically and the aorta as the superhighway of the body, bringing things around. And then when you branch off into tissues, that's more like city streets and neighborhood streets. So the ABI is a really good marker for the superhighway system, conduit artery and atherosclerotic disease. And not surprisingly, as a marker of conduit artery disease, it associates quite well with conduit artery complications. And so the risk of mortality, particularly cardiovascular mortality, finds a dose response with the ankle brachial index, where again, I told you with a reference of about 1.1 to 1.2, the rates of mortality are much lower. And as your ABI goes down, even below 1.0, you can see a dose response until you get to a hazard ratio of about 4. This is a meta-analysis of nearly 50,000 subjects and nearly 500,000 person years of follow-up. I'll point out, although I'm not going to spend any real time on this, is that when your ankle brachial index gets high, which is really a marker of non-compressible vessels in the lower extremities, likely due to calcification, that's also an adverse sign and a marker of vascular disease. And again, this is really what drove our field for a long time. PAD is actually a coronary disease risk equivalent, and we should be paying attention to it. But, the patients don't come in complaining that they've already died. They come in complaining that their legs hurt. And in fact, I think we have fits and starts in both directions, which is appropriate because it follows the energy of the field. But I think it becomes really important to understand why don't they feel well. And I'll say that if you want to understand how poorly they feel, what you need to understand is what you need to do is compare it to things that we see routinely in practice. And this is a physical component summary, how someone feels. This was done now 25 years ago. And the average adult has a score of 50. The average well adult, that's a fellow who's well rested after a weekend, is around 55. Intermittent claudication puts you in between New York Heart Association class 3 heart failure and chronic lung disease like COPD or emphysema. So the folks who have peripheral artery disease and have symptomatic manifestations of it feel basically terrible all the time. They can't walk anywhere. They're afraid to go shopping. Their social interactions are decreased. Their emotional functioning is impaired. Everything is more difficult because once you have PAD that's symptomatic and you can't walk more than a block, you're afraid to be isolated somewhere without any mechanism of rescue. And this has been measured. This is work by CUNY Matsushita's group, where they took a look at the ARIC study. 5,000 patients had another physical component summary. And what you can see here, and what everybody knows, is that once you sort of get below normal for your ankle brachial index, you begin to feel worse. Okay, so it's not really surprising that having PAD is a problem. But I think the next slide is going to begin to get at the real question here. So I told you that there was a very strong dose response between conduit artery occlusive disease and cardiovascular complications like heart attack, stroke, and death. All right, this is the relationship between the ankle brachial index and how people feel with that same physical component score. Yes, this is the p-value here is ridiculously small. It's nice to have 1,100 patients to look at this, but this is and I'm going to use a medical term now, a MIPSI-PIPSI relationship between the resting ankle brachial index and how someone is feeling about their physical limitation. And in fact, this is the post-exercise ankle brachial index, which really isn't even that much better. So post-exercise, your ankle brachial index drops more because basically all the blood vessels in your distal lower extremity dilate, and your blood pressure as measured in your arms usually goes up. And so that disconnect becomes worse, and it's thought to better represent and bring out PAD. And even in that circumstance, the relationship is really poor, making me wonder, how much is the progressive conduit artery disease really contributing to how people feel? Now, 5 years ago, there was a PAD compendium that was published in Circ Research, and Mary McDermott, a national, if not international leader in this field, wrote a really nice paper reviewing the proposed pathways for the association of lower extremity ischemia with mobility loss and PAD. And as you can see here, she began with occlusive disease in the legs, causing repeated ischemia reperfusion in the calf skeletal muscle. And as a result of that, there was loss of fibers, there was impaired mitochondrial function. And then as you were losing muscle and the mechanisms of using energy, you had worse oxygen consumption, reduced strength, and then your performance was worse. So all of this was a significant downstream consequence of conduit artery disease. So I'm going to switch topics for a second here and just talk about who gets fixed when they have symptoms. All right. And this is the most extreme case, and I'm using the most extreme case to make a very specific point. This is 4,400 patients who underwent a revascularization in Michigan, all of whom had an ankle brachial index before they had their revascularization for critical limb ischemia. So I'll now call this CLTI, which is now the newest word that we're using, chronic limb threatening ischemia. And what I want to point out here is that the ABI was normal in 25% of the people who underwent endovascular intervention and 20% of the people who underwent surgical revascularization. I don't really understand why you have to restore flow if you actually have normal perfusion pressure at your ankle. Now, I'll say some of these are clearly maybe pedal bypasses or pedal interventions, so that the distance between the ankle and the toe can sometimes seem like a country mile. Or perhaps there was some calcification involved and it was artificially elevated, or it wasn't completely calcified, so it didn't get above 1.4. But there is no way that we should be talking about somewhere between 1 in 6 and 1 in 4 people having a normal ankle brachial index, unless, of course, it's actually not PAD that's particularly the cause of the symptoms in the lower extremity. So here's a really good example of just making that case. This work looked at 1,244 men who had claudication. And you can see here in the blue line, the relationship between the development of ulceration, that's critical limb ischemia, across the spectrum of ankle brachial index. And across that spectrum, there was basically a doubling in the rate of developing critical limb ischemia over about a decade of 5 years, sorry. At every single level, that risk was tripled if you also had diabetes. So, and the stat that I use from this slide is an ABI of 0.1 without diabetes gave you the same 5-year risk of critical limb ischemia as an ABI of 0.9 in someone who also had diabetes. The one thing I'll take away, there's 2 things to take away here. The obvious one is diabetes is bad. And I don't have to go into how bad diabetes is, but my real take home from this is there's other stuff going on that's driving limb complications in the lower extremities. I really wanted to begin to figure that out. And so what we're going to be talking about is the way that I've been trying to figure out what is also driving the limb symptoms in the lower extremities. And so there was a very nice review published a few years ago that I think provided a very nice picture for how I've begun to think about limb symptoms in peripheral artery disease. And this comes from Viviane Ticchetti across the street, working with Marcelo DiCarli, and they've done a lot of nice work looking at coronary macro and microcirculation. This has nothing to do with the talk here specifically, because I'm not going to talk about the coronaries, but I will say that it points out quite nicely that when you have focal atherosclerosis over time, you can also have dropout of the capillaries. All right, you can have capillary dropout, and the microvasculature is a key player in how symptoms are perceived. And I'm going to be talking about this for most of the rest of the talk. Again, I want to just harken back to my original model. The conduit arteries are the superhighways of the body, bringing blood very long distances. But the capillaries are really your neighborhood streets. And as such, I want to make it clear that I think there's a very intimate relationship, a codependency with tissue and microvascular function. And so they don't move in opposite directions. They move synergistically. They affect each other's function. And when there is constant abnormal oxidative stress from the tissues and changing in metabolism, you can get capillary dropouts so that you then have fewer vessels that will subtend any portion of tissue, which then causes over time the dropout of muscle. And so you can begin to see how this is going to cause a problem. The second concept I want to get across, and I'll show you some data about this, is that we talk about conduit artery disease, systemic, that endothelial dysfunction, for example, is a systemic problem. That if you have it anywhere, you have it everywhere, just like atherosclerosis in the conduit arteries. And so I really began to think, and I began to think of a bunch of years ago now, that this is likely true in the microvascular disease system as well. And so here are the common places where we see and measure microvascular disease: retinopathy, kidney disease, obviously heart disease, as I just mentioned, and neuropathies. And so I want you to bear in mind that I'm now beginning to create an analogy between microvascular disease and larger conduit artery disease as well. So what's my proof that this is a systemic thing? Here's one. This is a nice study looking at gluteal resistance arteries. So they biopsy the gluteal muscle, and then they prepare it and expose it to acetylcholine. And you can see here that the patients who have microvascular angina, as measured with axial imaging studies of the heart, tended to have a much lower response to acetylcholine than people who did not. This is a really nice study by Cohen Steenhauer from Denmark, where they took a look at the Maastricht study of 2,000 people, and everybody underwent, on the left side, heat-induced skin hyperemia. So this is a microvascular skin function, or flicker light-induced retinal arteriolar dilation. This looks at the retinal arterioles. And there are, for every one of these models, crude, and then as you add on more sex, age, and socioeconomic stuff, and diseases, 3 columns here. So the people who had, the column you do not see are the people that they have normal glucose metabolism. The people in the dark bars are the people with type 2 diabetes, and not surprisingly, they have what looks like systemic, at least impairment in microvascular function. And, you know, in the United States, that's somewhere 30, 35 million people probably. But the bars that I think are the scariest are actually the white bars. The white bars are people who do not have diabetes, they have pre-diabetes. And you can see that no matter how much controlling you do, that this group of people, which represents 50, 60 million people, also has a systemic impairment in their microvascular function. And then is there evidence that if it's in one place, that it's in another? So the presence of microalbuminuria predicts cutaneous microvascular vasomotion and perfusion. The more microalbuminuria you have, the worse your microvascular function is. So it could be a kidney in origin problem causing a skin problem, or it could be a systemic issue. Let me continue to show you evidence that it's a systemic issue. This is a study in the Wisconsin Epidemiologic Study of Diabetic Retinopathy. There are several important points here. One, it's nearly 1,000 patients, which is in each group. And number one, the most important thing and the most discouraging thing is that they decided that old was over the age of 30, which means I feel like I'm decrepit at this point. But if you are under the age of 30 with diabetes, look at the range of retinopathy severity, and then look at the relative risk of amputation in those groups. The worse your eye arteriolar disease, the more likely you were to have an amputation. Now, I can't think of microvascular disease that is any further than from the feet than the eyes. This was also equally true, if not worse, in the older subjects. So older, like 32, which I would guess is some of your, there must be at least some fellows in that category. And you can see here that as your retinopathy severity gets worse, your risk of amputation gets worse. And so there's clearly some relationship there. And it's not just eyes, it's kidneys too. This comes from the Geisinger Health System, 4,500 patients. And just take a look, we can just take a look at model 3, which is basically throwing absolutely everything into this model. And in the total subject cohort, the relative risks increase as your microalbumin increases. And then even in the diabetic subjects, there's a bit of an increase, although I will say this is not nearly the same difference. So it's on the basis of this kind of work and trying to understand what's going on that we applied for and got one of the strategically focused research network grants from the AHA in vascular disease. And the title of our overall project was Microvascular Disease Determines Limb Outcomes in PAD. This is another one of those places where it's really nice to work in a place that has a collaborative bent as part of its culture. So to get the other 4 people involved in this call required 2 emails, 1 text, and I bumped into someone in ABP. And that was it. Dave Wasserman is a named professor, a named basic science professor, and you're not going to know who he is because he considers himself a bit more in the diabetes space, although the truth is he's really a mix between diabetes and microvascular disease. There's me, there's Matt Freiberg and Quinn Wells, who are looking at both the population work and genetic architecture of microvascular disease, and Joey Barnett, who does a lot of work with the AHAs running our training program. This has really been the foundation of a research working group on peripheral artery disease and understanding limb outcomes. So the first thing we did was we took a look at the Veterans Aging Cohort Study. This is a study that we were able to include 125,000 patients. We followed them up for about 11 years. And then we separated them into groups in the VA based primarily on ICD-9 codes, also CPT codes. And we used a published measure by Bali and colleagues from vascular medicine to create this model since it had already been published and we didn't want to recreate the wheel. So what you can see here is that if you had neither microvascular disease nor PAD, your risk of amputation was pretty low. Your incidence rate per 1,000 person years was 0.23. And out of these 795,000 person years of follow-up, there were 180 events. This obviously speaks to other causes more than any, or missed vascular disease, but really kind of uncommon in this population. If you had microvascular disease alone and no peripheral artery disease, your unadjusted hazard ratio was nearly 7. And even after we adjusted for everything that you can see in the bottom of this slide, your adjusted risk of amputation was nearly 4. If you had peripheral artery disease and you had no microvascular disease, your risk of amputation after all adjustments was 14. And if you had microvascular disease and PAD together, this is an adjusted hazard ratio of 23. Now, not 1.23, 23-fold. Now, one of the good things that we were able to do, because the veterans come back for their at least their annual appointments, is we were able to time update these samples. That's why I can't give you a certain number of people in each group, because people were allowed to change groups through this time period as they developed new illnesses. But if you looked at the total number of people in an unadjusted way, This is the figure that you get, and you basically dance around your office for a while. These are the people who had nothing at the bottom. I don't even remember which one it is anymore, but these two are microvascular disease alone and PAD alone. And then this is the combination, demonstrating that the risk of amputation is not just additive, it's potentiated by having two. So microvascular disease is its own contributor, for example, to amputation. And we began to think about this problem as, let's say, an aggregation of risk factors. This is a list. This is not a complete list, but I had to make a figure for a paper. So these were things that I could think of that would have reasonable images, ranging from tobacco use to insulin resistance to endothelial dysfunction and function. And sometimes people get peripheral artery disease, and that can increase your risk of amputation by 14-fold. And sometimes you get microvascular disease, and that can increase your risk of amputation by 4-fold. And many more people have microvascular disease than PAD. And then the combination again increases your risk of 23-fold. Now, we got a lot of questions about this data when we submitted it. And the first one, and the one that everybody has all the time, is this is just diabetes you haven't picked up. So the answer to that question is no. These are the same groups of people who were free of diabetes, no diabetes diagnosis over 11 years. And what you can see is that if you had none, microvascular, macrovascular, or both, the relationships are the same. We did the same for people who never had renal disease, same relationship, people who were never smokers, people who never had high blood pressure, and we did HIV because we had previously published that HIV increases your risk for PAD. So you did not have to have diabetes. This was a microvascular disease and origin problem. The conflation, I'll just say, made by most people who are in this field is that diabetes is really common and is the most common way that you look for retinopathy and nephropathy and neuropathy. But the truth is, diabetes is not the #1 cause of microvascular disease in the United States. The #1 cause of microvascular disease is hypertension with proteinuria or microalbuminuria. And so there are actually many ways, those two probably being the most important, of getting to microvascular disease. So once you begin to say to yourself, okay, it's the microvessels, does it matter where your microvessel, where your dysfunction is based on what kind of amputation you're going to get? And so we took a look at the folks based on their kinds of disease. And if you had neither, there was kind of a splay all the way across. It wasn't really separated very much. If you had microvascular disease, you were much, much more likely to get a distal amputation. If you had PAD only, you were much more likely to get below knee or above knee amputations. And again, if you had microvascular disease and PAD, every number was higher, but you had a greater proportion of larger amputations than microvascular disease alone. I want to make this point here, and I'm going to show it more specifically in the next couple of slides. There were people who had microvascular disease alone who got above knee amputations. This number numerically is not very high, but this is not something where you can say it's just a toe, you don't have to worry, it's only a toe. 15% of all the amputations in the people with microvascular disease were below knee amputations. So then people said, okay, but this is just neuropathy. Everybody has neuropathy. And again, you know, I'm as a firm believer in the systemic microvascular disease hypothesis. I said, okay, let's see if that's the case. And we took a look at the data, and you can see that for the people who only had retinopathy in the top row, 5% of the amputations in that group were above knee, and about 3% were below knee. You could have microvascular disease be clinically evident as far away as possible from the feet and still have amputations. The other thing I'll point out from this is that as you aggregate clinical manifestations of microvascular disease, so any two, it gets worse, and then all three is the worst state. Now, I do want to make the point that I'm not trying to diminish the importance of neuropathy in the development of lesions, right? Because neuropathy allows you to have injury that you don't feel, and certainly makes it worse beyond just the microvascular disease. But you do not have to have it. You could have nephropathy and retinopathy and still have a pretty impressive rate of amputation. So, part of this is part of the other problem that we have is that sometimes it's hard to detect peripheral artery disease. And, Skylar Jones, and I know that Eric has been doing a lot of this work. I would say we're all a little bit suspect about ICD-9, ICD-10 codes, CPT codes. It's not a perfect way of figuring this out. And 4413, a 4491.13, I'll say when, Skylar Jones has evaluated this, there's a very strong component of venous disease and other crap in there. And so it's hard to figure out because lots of people don't have typical symptoms. The symptomatic forms are much less common. And so we decided when we were doing this grant that we were going to figure out other ways to understand in the larger VA cohort and the Vanderbilt cohort who has this disease. And so we basically got our co-investigators at the University of Utah and commissioned the development of a natural language processing tool, which would have been done about, I don't know, a year ago. And then there was like this crazy pandemic that stopped a lot of work. We have completed parts of it, and I'm going to show you some of the results of that, which have brought up some interesting things to understand what's going on. But natural language processing is where we're going to better understand our patient set and use patient-based data, whether it's imaging studies, it is words in the notes, or it's the ankle brachial index that has been done. So one of the first ways that our natural language processing tool was validated was with Derek Claren and Scott Damrauer, where they were doing a GWAS in the Million Veterans program, and they tested 32 million DNA sequence variants in PAD, 31,000 cases, and about eightfold as many controls. And you can see who was involved here. There were, among the veterans, a decent percentage of white veterans, Black veterans, and Hispanic veterans. And then they replicated this information with data from the UK Biobank. I'm not going to go through all the different SNPs. There were about 8 SNPs that were found in PAD that were not found in coronary disease. But the one that I think is really very interesting and has relevance to stuff we do on a daily basis right now and suggests that we should be paying attention to is a factor V Leiden variant. So there was a factor V Leiden variant that really had no relationship at all to coronary disease or stroke. Okay, nothing. I mean, these are, with numbers like we're talking about, we should be able to see something. But if you take a look at peripheral artery disease, there was a dose response, so to speak, as your peripheral artery disease got worse. And this was also modified environmentally by the presence or absence of smoking, which I found incredibly interesting. Now, factor V Leiden, we always associate that with a venous thrombosis problem. It's not even a particularly good predictor of venous thrombosis or its recurrence. Is this really important? And so things happen at the same time for unrelated reasons. And if you're lucky, sometimes you can step back and see a bigger picture. We all know about the COMPASS trial, and the COMPASS trial tested arterial dose rivaroxaban 2.5 twice a day with or without aspirin. And there was, this is the PAD subset of 7,400 patients. And there was a dramatic and early benefit in the PAD group. I will point out to you that factor 10 activates prothrombin with the assistance of activated factor V. That this would be a spot where this medicine may interrupt what's going on genetically. And what's even more important for this talk, and as we move back towards the symptoms of lower extremity disease, aspirin and rivaroxaban reduced major adverse limb events dramatically in people with stable PAD. Okay, there's only 2 drugs that really ever improved limb outcomes. And one of them was rivaroxaban, the others were Paxar. You can make a comment that this was not prospectively one of the primary endpoints, but then I'll point you to the recent Voyager trial published by Mark Banaka and colleagues. These are people who came in and had revascularization in their lower extremities, and the addition of rivaroxaban in the arterial dose lowered the rate of acute limb ischemia, vascular major amputation, MI, ischemic death, and stroke. Secondary endpoints include reductions in unplanned revascularization and amputation. So is thrombosis more important in the lower extremities than we previously appreciated? Another really interesting paper came out from Newport and Narula. This is from his review article after that, where they were looking at pathological disparities or differences between PAD and CAD. These are typical coronary disease lesions, and everywhere you see a black arrow, you're seeing a lipid core, basically. All right. But if you take a look at the same, these are samples now from patients who had critical limb ischemia and had amputations. There's almost no lipid core. There's a lot of calcium, as you can see in A, and everywhere you see a yellow arrow, you see thrombus. These are in hundreds of subjects. And so it looks like below the knees, atherosclerosis is not the most important contributor, that it looks more like what we used to call arteriolosclerosis, with calcification, wall thickening, and either in situ thrombosis or embolization of small amounts of more proximal thrombotic components of plaque. And so you begin to say to yourself, you built this natural language processing tool, which you never conceived of would be involved in a genetic study, but was used there to confirm the diagnosis. And then you realize that a medicine that interrupts the pathway that was discovered has incredible outcomes. And you then have pathology that demonstrates, it looks like thrombus is really important. And it's really important in the smaller vessels, and you begin to tell a story. So then I wanted to begin to understand what metabolism was doing. And I really thought metabolism was an important way of understanding sort of the output of the intimate relationship between the microvessels and the skeletal muscle. And the first model that we did this in was the one that I've published a million times, which is brachial artery flow-mediated vasodilation. And in this model, this is not drawn to scale, but what you can see here is an arm with a blood pressure cuff, and we use an ultrasound probe to look at the conduit artery in the lower upper arm, and we look at it at baseline, and then after 5 minutes of ischemia with the blood pressure cuff at suprasystolic pressures. The way that we changed this protocol a bit was that we put an IV in to the cubital vein here so that we could capture arm-specific efflux, both at rest and then right after cuff release. So at rest with no problem, and then with ischemia present. So we did this in healthy subjects and in diabetic subjects. And these are nice stark examples. We obviously measured more metabolites in this, and I'll show you a bigger picture in a second. But a lot of these are in pathways that you all find familiar. This is in the branched chain amino acid pathway. This is TMAO, which is all over the place. This is in the serotonin pathway. I put this one up here because serotonin is a vasodilator. And what you can see here, and what I find really interesting for the three I just pointed out, is that you start off with pretty similar levels at the resting state, but the diabetic patients are unable to bring these into the tissues, and they remain in the blood in the setting of ischemia and cannot be used as fuel and taken away. And then you say to yourself, now I understand why people with a high level of TMAO have worse disease, because it never leaves their blood. You can't take it up. What we found really interesting is you take a look at these heat maps, is that there was an incredibly coordinated response in the diabetic subjects on the left and not at all in the healthy subjects on the right. And then we were able to demonstrate that there was a relationship between changes in metabolites at the 5-second time point and your endothelial function. This was particularly in the phosphatidylcholine pathway, and you can see that it involved down here. Everywhere where you see a star is significant, and this is really significant, that there's just different directions between the solid lines of the diabetic subjects versus the dotted lines of the healthy subjects, and what happens to these metabolites. And acetylcholine, which is an endothelium-dependent vasodilator, acts differently between the two groups, and these associated with endothelial function. When we brought this together and took a look specifically at branched chain amino acids, I had conversations with Will Hyatt, may he now rest in peace. 25 years ago, in biopsy studies in calf muscles of people with peripheral artery disease, Will was able to demonstrate that there was a significant increase in short chain acylcarnitines in the muscle. And that work kind of died because nobody really understood where they were in the metabolic pathway. We now know that they're intimately tied to branched chain amino acids. And so I began to create sort of an understanding for myself that linked increases in inflammation, oxidative stress, and dysmetabolism in the muscle with increasing amounts of branched chain amino acids, with their catabolism, the development of acylcarnitines, and then the increase in 3-hydroxyisobutyrate, which then causes the increase in the expression of fatty acid transport protein. And now you begin to see why there's more fatty acids in the muscle, but excess fatty acids actually causes endothelial dysfunction in the microvessels, and over time, you develop capillary dropout, which then causes more oxidation and local insulin resistance and renews and enhances the cycle. Just remember that every microvessel runs in the most metabolically favorable position in relationship to the nucleus of the skeletal muscle. And when you have dropout of the microvessels, these vessels become further away from where you want to have an easy exchange of fuel and waste. So one of the folks that we engaged was David Wasserman, and he's been studying the microvessels in mice in living in vivo models, and I'll show you the picture in a second. But as we take a look at the microvessels here, again, I want you to remember that they run along the striae of the muscle right next to the nucleus where the mitochondria sit. So what Dave has done and is able to do now for a long time is that he can use intravital microscopy on gastrocnemius muscle in living mice and then change their conditions. He runs one of the national cores for the NIH in this area. And the first thing he did, and this is one of the reasons that I was really, that he was nearly finishing with this work, was he wanted to figure out, and this is what the pictures look like, by the way, okay? He wanted to figure out what limits insulin's access to the muscle. And it turns out that it's not a receptor-mediated issue. Please don't ask me to explain the math. I cannot get to this level of mathematical modeling. But what he was able to demonstrate was that insulin is diffusion limited across the interstitium between the tissues, between the vessels and the tissues. So I'm a very basic person, but that means the fewer vessels you have, the further the insulin has to travel. Glucose, by the way, is perfusion limited. So the fewer vessels you have, the less glucose actually can get to the tissue. We wanted to figure this out in human beings, and so I linked up with my MRI colleagues in the Vanderbilt University Institute of Imaging Sciences, Manus Donahue, who none of you may know, but the guy is a genius in imaging and does incredible work. It started off in cerebrovascular disease. I got involved with them with a lipedema and lymphedema project, and these are just pictures to show you what we can take a look at. The top left are M. Dixon pictures with and without fat suppression. We can take a look at sodium and water in the tissue, T1 and T2 weighted fat saturation. We can look at perfusion in the tissue and exclude the conduit artery. And we can take a look at the oxygen extraction, which primarily comes from venous oxygen saturation. And so a lot of the work I'm going to show you now was done by a fellow who's been working with me named Adam Baruzian. And I have to say, through thick and thin, tornado, pandemic, and everything else, he has been a true soldier getting all this work done. And really, our conversations back and forth really have helped me understand all this work even better. But one of the techniques we used was blood oxygen level dependent MRI, which utilizes differences in magnetic properties of oxygenated and deoxygenated hemoglobin. And what we were able to do, and we used the same model that we used in the arm, where we had a cuff around the upper part of the calf, and we took a look at the relative signal of baseline after the cuff was inflated, and it's hard to see there because there's really no blood flowing at the time. And then the real key determinant here is upon cuff release, which is at the green arrow. And there's a bunch of parameters that you can measure here. One of them is how high the reperfusion goes. More is better, blue is normal, versus how delayed the reperfusion is. And you can see here for the in the orange line that the time to peak perfusion is delayed in the people that have peripheral artery disease. And so again, looking very specifically in the skeletal muscle, not at the conduit artery for these changes, this is an abstract that Adam had accepted at the ACC, which now unfortunately is virtual for those of you that haven't heard. And you can see that there's an R-squared relationship between maximum reactivity or time to perfusion and how far people can walk in a 6-minute walk test. This relationship was stronger than the relationship with the ankle brachial index. And its flow, it is microvessel flow in the skeletal muscle that is an incredibly strong determinant of how far you can go. As we take a look at oxygen extraction, the oxygen extraction fraction, again, I'm sorry about the slide. I think I went from a wide format to a narrow format. But what you can see here is that the PAD subjects who have less flow, slower flow, have a much greater oxygen extraction because they basically have to get the oxygen from somewhere. And that is pretty related to the ankle brachial index, demonstrating that if you can't get blood even in, that is an important determinant. It's not the only determinant, but it is an important one. Finally, I want to end on some cool pictures because I always think like it's good to end on cool pictures. And one of the, you come into a new place and you learn what they find interesting. One of the things that they found interesting is that sodium and sodium tissue deposition is not like what I learned about in medical school. Sodium is not just that thing that goes in and out of tissues and more sodium makes you hold on to water. Sodium gets deposited over your lifespan in the extracellular matrix. And so everybody basically develops their own salt licks, for example, in their skin. And when you have an injury, it is part of the inflammatory process and salt gets deposited. And in fact, you can see it on MRI, and I'll show you what that looks like in the skin and the skeletal muscles and the blood vessels, and it activates macrophages. One of the ways that it does that is through standard pro-inflammatory activation methods, and it inhibits the non-inflammatory macrophage activation. So it actually helps you clear pathogens, but it can also delay wound healing, which suddenly becomes a big issue if you're trying to understand what's going on in the toes of patients who have lots of sodium deposition. I'm going to show you what's going on in the skeletal muscle, what is part of the pathophysiologic process in patients who have peripheral artery disease. And this is really how the scan is done. Here's a nice picture. Here you can see very easily, and I'll show you these separated, the skin, the subcutaneous adipose, and the muscle. What they do is they create probes that have different concentrations of sodium chloride, and then you compare. So, even if you're mildly colorblind, there's a lot more yellow and red and a lot more blue here in the healthy controls. There's a lot more salt just deposited in PAD. Here's just skin sodium and muscle sodium. I'll show you these again in a minute. As I show you what the pictures look like, with this MRI, we can separate out the skin, the subcutaneous adipose, and the muscle. And you can see that at every layer, there is more sodium deposited. There is a more inflammatory tissue in the subjects with peripheral artery disease. And this is at baseline before their exercise therapy. And just to put this all together, more skin sodium, more subcutaneous adipose sodium, more muscle sodium, and interestingly, a lower fat-water ratio. So this is not a situation where sodium is dragging in water, which is what we usually think about, for example, in things like congestive heart failure. All right, I want to show you one last thing that we're doing with our NLP so I can brag about Aaron Aday, who's come down to join us. One of the first big things we're doing with this NLP tool is looking at every ABI that was done in the VA birth cohort of 6 million people. And we have 270,000 people that have had ankle brachial indices. We looked at the people, and we go down to the 87,000 who had normal ankle brachial indices in 2 legs at baseline with no other indicator of peripheral artery disease. And we wanted to see what was happening to them over time. We're sending this in somewhere in the next week or so I feel comfortable telling you about it. One of the big questions in our field is, are there race and ethnic disparities in who develops PAD? And figuring that out is really tied into what time you present, how late do you present, what's your local medical care like. This is a national medical sample. And what you can see here is that there is no difference between white patients and Black patients over the course of 15 years, 5,100 incident cases in developing peripheral artery disease. Stay tuned, because the rest of the story will come out in the paper, but I just wanted to wet your whistle for things that we're doing that we're going to be able to begin to understand from this incredibly large data set using our tools. And in summary, leaving hopefully 5 minutes for questions. I think we're missing millions of patients who are at increased risk of amputation, mostly because we're missing the link between microvascular disease, amputation, and PAD. We are at the beginning of a new era of discovery as we have much better tools in metabolomics. And I should mention, of course, that I've been collaborating with the chief, Dr. Gersten, in doing this work, and he's made this really easy for us. But just doing the EHR-based work with people like Eric and Bobby Ye, you guys are at the forefront of doing some of the more important and interesting things. And I'm really happy that we've been able to bring some other tools online like MRI. And then these can hopefully generate novel therapies that can significantly alter outcomes in PAD. And with that, I'll say thank you so much for your attention, and I'm happy to answer any questions. Stunned silence. Perfect.
I'll ask a question, Josh, if I can. It's Brett Carroll. Thanks so much for taking the time to join us today. You know, we hear a lot of talks about PAD, but this is the first I've heard really focusing on microvascular disease, and appreciate your comments in that it's not just a plumbing problem. How do you utilize the finding of microvascular disease in practice in terms of, you know, really making sure these patients that maybe have subclinical, mildly abnormal ABIs and microvascular disease, are you being more aggressive up front with your medical management? You know, we try to emphasize that all patients with PAD should be optimized maximally in their medical management, but how have you used this data so far in your practice?
Mostly as an alarm system, as you've just described. I think it's, you know, I have a clinic in the diabetes clinic, and at the same time, there's a podiatrist there. So I send him a lot of patients for people who I think are on the borderline. I'm also much more aggressive in using at least standard therapies and getting LDLs lower, using an aspirin, putting people on an ACE or an ARB. If they have any PAD, particularly if they have either polyvascular disease or, for me, microvascular disease, I'll start them on low-dose rivaroxaban. And you have to have a long conversation with these patients and say, you know, your feet are at risk. Wear shoes at home. Look at your feet every single night. Please don't cut your toenails by yourself for a lot of these folks. So I think that there's, at the moment, what we've done mostly is be able to create a risk profile. What I'm hopeful is that, you know, one of the other aims of our research network grant is to look at people before and after exercise and before and after revascularization to understand the difference between a metabolic improvement and a blood flow improvement. And I'm pretty sure they're not going to be exactly the same. Once we begin to understand the metabolic changes, and we actually have tissue from the calves, so transcriptomic changes, I think we're going to begin to figure out where we can move forward. It would not be surprising to me if the GLP-1 receptor agonists were beneficial here. In a retrospective of LEADER, there was a reduced rate of amputation, and that was not impacted at all by the number of revascularizations.
A few.
Great, thank you.
Yep.
Josh, this is Frank Lagerfo from across the street at BI Deaconess, and I'm delighted to see you focusing on this problem. Of course, I go back to the Jay Kaufman era, And where we pointed out 1984 that it's not a microvascular occlusion, but a microvascular dysfunction, which you are showing here very nicely. I encourage you to take into consideration the role of the neuropeptide system, which, by the way, is altered before you can detect sensory or motor neuropathy. So there are ways to detect it. But those 8 or 10 neuropeptides released point by point within a millimeter of each nerve ending in your skin control a lot of the physiology in the microcirculation. And in the heart, where neuropeptide Y is co-secreted with norepinephrine. I think if you put those two things together, it may complicate the picture a little bit, but I think there's probably some cross influence between that very complex neuropeptide system and the microcirculation.
So, Dr. Legurfo, I know certainly who you are, and you've taught me many, many things. And your work and the work of Aris Veves has been really instrumental in this area. And so I have not been focusing on it because you guys, this is a part of the market that you have cornered. But we will be able to take a look at these with some of our tools. And I think in some of the biopsy samples, we may be able to get an understanding of this as well. But I will take your point, and I'll just expand it for the rest of the audience by saying this is another cog in the wheel, and there are many. I'll just give you one simple example. Calcification of pedal vessels may be incredibly important in why revascularization fails and people still need amputation, despite having a pretty restored ABI after a procedure. So there's a lot of stuff that's going on, and I take your point. It's an incredibly important contribution here, and I'm hopeful that I can just continue to contribute, at even half the rate that you did.
Hey, Josh, this is Alex Schmeier. That was a fantastic talk, and I think it, in hindsight, it almost seems obvious the importance of the microvasculature, and especially these data parallel a lot of the stuff that Marcelo and Viviani have done with microvascular disease in the coronary circulation and cardiac endpoints. And a lot of those data point out major gender differences that women seem to have endpoints driven by microvascular pathology, whereas men have often macrovascular pathology. Do your data point out any differences in microvascular pathologies between women and men in peripheral disease?
So the study I showed you is basically a 20 PAD, 20 control subject population. I'm not really sure we have enough to be able to figure out sex differences. We'll certainly look. I don't know if you saw, Iris Jaffe, myself, we published a paper in Circ Research on sex as a biological variable in atherosclerosis. So I'm certainly attuned to the issue. It'll be, even if we're 10 and 10, I think it's going to be hard, but we'll look, and we'll also look at some of the other risk factors that come with that. And I agree with you. There's just as men and women are not the same, as I've learned throughout my entire life, literally on a daily basis with my wife.
Very good.
I'll let you know.
Do we have any other questions? Please feel free to send them on the chat or come off of mute. Josh, I had one question. I know you work very closely with the cardio-oncology group at Vanderbilt, and I was curious to what extent you see patients on VEGF pathway inhibitors showing up in your clinic. Certainly the phenotypes can be diverse, and I've seen some work suggesting that microvascular ischemia may play a role.
Yeah, that's an awesome question. So so you may not know that we published a paper on VEGF inhibitors in breast cancer. You may know that's why you're teeing it up and being nice to me. And it clearly alters vascular function, most probably in smaller vessels more than conduit arteries, oddly enough. I'm currently working with Javed Moslehi. I'm a co-investigator on a grant where we're looking at VEGF receptor inhibitors and the immune channel, the ICIs to take a look at their effect on vascular function in patients with different, mostly renal cancers now. Yes, I think that I see them mostly for their hypertension, although we've pretty standardized now the management, and it doesn't really matter what drug you use as long as you lower the blood pressure a bit. But it's clearly a microvessel greater than conduit artery problem, although not entirely, because you can see strokes and myocardial infarctions as well. But I think that's the tip of the spear. There's a much bigger picture in other places.
Great, thank you.
Hey, Josh, it's Dwayne. Good
Hey,
to see
Dwayne,
you.
how are you?
I'm good. Miss you. Given what you've been talking about, and I guess I have to revise, I'm still old, I'll refer to it as critical limb ischemia. This concept of restoring inline flow to save legs.
Yeah.
It seems like we're outdated, and are there going to be different paradigms? What's it going to take to change it? And what do you think is going to be shown, or are we missing the boat with best CLI?
Yeah, so, I remember being in a grand rounds when I was a resident in the 90s, and someone came and talked about the concept of systemic atherosclerosis. And, when this was a new concept, of course, someone raised their hand at medical grand rounds and said, so are you assuming that we're not going to have to cath anymore? We're only going to treat people at the system-wide level, and it's just going to be medical therapy? Is the game over? And obviously, this was in the mid 90s, and the answer to that was no, of course not. And so I think that it's going to be more of a combined approach. I think microvessel function is going to have to be a much more medicine and oriented method of trying to improve it. Medicine and exercise. I think that, of course, conduit artery disease is important. And I showed you earlier, and I know you saw this, that PAD is an incredibly important cause of limb dysfunction and amputation. So I don't want to minimize its importance. What I think the answer is that we're going to begin to figure out in a more visceral way which patients will benefit from revascularization and which won't. There's some really interesting work, primarily from the vascular surgery literature, showing that, say, for people who come in with wounds, there's a proportion of them, 15%, 20%, that will heal without any revascularization. I don't think we have a good prospective way of understanding who those people are. And I'm hoping that I can contribute, at least in some way, to beginning to figure that out. And it may end up being that the people who don't have microvascular disease will heal better. And the people with microvascular disease need to have that other complication of large vessel occlusive disease fixed so they can overcome the more local microvascular disease problem. I don't really think you're going to be out of business anytime soon. My goal is really to understand what's going on so we can target our therapies, which are getting better and better, in a more efficient and effective way.
Okay, we'll keep Zasemski on then.
I think so. He's worth it.
Wonderful. Well, thank you so much, Josh, for joining us. I think we all really enjoyed this lecture and enjoyed the opportunity to interact with you. And hopefully next time it will be in person.
That sounds great. I would love to see you guys in person. I hope everybody keeps well. And I can't tell you how flattered I am that I was invited. Thank you so much.
All right. Thanks. See everyone next week. Thank you, Josh.
Bye, Arthi. Nice to see you.